And welcome to Windsor-Essex County Health Unit's media briefing for January the 27th. We are joined today by the CEO, Nicole Dupuis, our MOH, Dr. Nessa Thury, and our Manager of Epidemiology, Ramsey D'Souza. We will start today with some opening remarks from Nicole, and then we'll move into our epidemiology summary. Thank you. Go ahead, Nicole.
Okay, thanks. Good morning, everyone, and thanks for joining us. We want to start off today acknowledging that yesterday was Bell Media's Let's Talk Day, a national campaign highlighting the importance of talking about mental health. Today, we want a few minutes to continue these conversations and focusing on children's mental health. The last couple of years have been challenging for all individuals, especially for children and parents. Transitions from in-class to online learning and back again have disrupted key aspects of healthy growth and development, including children's education and everyday experiences such as socialization and physical activity. There are many things that parents and caregivers can do to support children's mental health and their overall well-being. Adding structure to your days. Kids do best when they're in a predictable routine, and something as simple as keeping a routine at home wherever possible can go a long way to ensure that kids continue to feel secure. Structure and routine is also important for parents, reducing stress and chaos of our everyday lives. Staying up to date on COVID, but not focusing on it more than necessary. Continue to talk to children in age-appropriate ways about COVID-19, but try to avoid talking about it more than is necessary. Giving your child or children confidence by reviewing public health measures and letting them be a leader and an expert in their own environment. Create opportunities to be active and to connect with others wherever possible. Extended indoor time indoors is difficult, and we can fall into a pattern that is inactive and unhealthy. Try to make sure that your children are engaging in various kinds of activities, not just in front of the screens. Examples like cooking together or art projects, active indoor games, things like hide and seek, and using video chatting to continue socialization when in-person visiting is not an option. Just like before the pandemic, some children will face more significant mental health challenges, and we know that these can be worse during this time. It's normal to have ups and downs in moods, but sometimes a more serious mental health issue will develop. More than half of mental health challenges begin in childhood or adolescence, and approximately 1 in 5 children and youth in Ontario live with a mental health challenge. Parents and caregivers are in the perfect position to identify issues early on so that children who need extra support can get the help they need. It's important to maintain an awareness of your child's wellness over time so you can easily identify changes in their mood or behavior. Make sure you're talking with your children and listening to them and hearing what they're saying. Pay special attention if they say that they feel sad or anxious a lot or express thoughts of hurting themselves. Take notice if a child has changes in behavior or emotions, such as angry outbursts, depressed moods, that last for some time. So, changes in their normal behavior, what would be normal for them. Like adults, children who are having a difficult time can benefit from speaking with a professional. Some options locally would, you can call 211 or visit 211ontario.ca to find mental health resources for children and youth in Windsor-Essex. As well, for youth, Access Kids Help Phone is available 24/7 at 1-800-668-6868. And their team of trained counselors provide free texting services and live online or live telephone chat for kids, teens, and young adults. And the services are both in English and in French. And of course, locally, we do have the Regional Children's Center at Hotel du Grace Hospital, mental health services focused for children and youth, as well as teen health through the Windsor-Essex Community Health Center, which includes confidential and free services for youth ages 12 to 24. And as always, if your child is in a crisis, immediately seek help from a mental health professional or contact your primary care provider. While COVID-19 has taken the focus of our collective attention, the mental health and well-being of our children and youth must continue to be a priority. And thank you.
Thank you very much, Nicole. So Ramsey, we will move into your epidemiology summary now.
Thank you, Ashley. I'm just going to share my screen quickly. Okay, so for today, it'll be less so on the epi summary itself, but more so on the changes that were made to our reporting here as a healthy when it comes to COVID-19. So just to provide a bit of a history, so when COVID or when the pandemic first took place in Windsor-Essex, we were conducting ongoing routine surveillance for all of our cases because there was access to testing. What this allowed us to do was identify community clusters that we first identified a large one towards the end of the summer of 2020. Our hockey-based clusters are large from farm outbreaks, the rise in school cases and closures that led to that as a result, and many other public health interventions as a cause of our case to contact management. To understand how it works, these are the indicators that we would typically use to monitor what's happening in our community. It would be our 7-day moving average, our weekly incidence rate, understanding the age and breakdown of our cases, to know what's currently driving our cases and where the case is coming from a geographical comparison, and also looking at how cases are acquired in COVID-19. Additionally, we would also look to see how rapidly our cases are increasing, and more importantly, comparing our numbers over time and also to other jurisdictions to see if the issues are pertinent only to Windsor-Essex, or are we seeing the same types of issues that are happening overall. The goal of public health surveillance is to conduct ongoing routine monitoring and assessment of the situation, and in this case, COVID-19, to help inform the decisions that we make. Towards the end of December, due to the surge of Omicron, we had to prioritize that as a province in terms of our resources, and in order to protect the healthcare system across the board. What this led to was changes to our testing eligibility, which did impact how case and contact management will be done, and in terms of who will be eligible for a test. So in terms of the changes that had to be looked at from a public health surveillance and epidemiological perspective, we want to still conduct as much of a systematic, robust surveillance and understanding COVID and how it's driving what we're seeing locally in our community. But what we had to first do was identify what would no longer be possible in terms of comparisons to what we're seeing prior to. So it was no longer possible to look at a 7-day average because we were only testing a segment of our population, so that number is not comparable. Same thing with our weekly incidence rate. Our age and sex breakdown as well would be very limited to a certain subset of the population that could either inflate or potentially mislead where cases will be coming from. With the widespread transmission of the Omicron variant, acquisition would also be a misleading factor in terms of knowing how one did acquire COVID-19. With the change in testing eligibility as well, we can no longer compare across different geographical regions because previous comparisons looked at all cases, whereas current comparisons we only looked at a certain population, which is limiting. And when it came to our outbreaks were also limited in the sense that we're now only focusing on our high risk settings as well. So what we wanted to do was find alternative measures that could help us give a sense collectively of what is happening in Windsor-Essex. And this is where we were able to work with our partners at Windsor and with the ministry to increase sampling of our wastewater data so we have a better sense of how transmission could be happening in our community. So what we wanted to do as well was, as you see in the slides, the ones that are crossed out are no longer being reported on by our health unit, and the ones currently available or added in red are the indicators that we want to focus in on. Specifically, it's looking at our current outbreaks, looking at the impact on our healthcare system, still using percent positivity, but as a proxy to kind of understand that our numbers, where our tests are turning positive, and what does that mean in terms of the current phase right now in terms of the pandemic. So as I mentioned earlier, these indicators would help us assess where we are currently, and can we make some overall collective identification of where we are headed in terms of the pandemic locally in Windsor-Essex. So I'm just going to quickly go into our dashboard as well, which we've had to modify. This was a two-goal process in the sense that we wanted to provide up-to-date, accurate information to our residents and to us and ourselves internally in terms of monitoring COVID-19. Additionally, as well, we also had a secondary goal of wanting to provide some additional content to our residents in terms of understanding historical aspects of our outbreak too. So on our first page, we've reduced the number of data elements that we wanted to present and kept it consistent in terms of what we had presented in the previous slide deck. We have distinguished between where our high-risk cases are and what constitutes as all cases prior to when testing was more eligible. Once again, these tests are an underestimate in terms of our high-risk cases, which means our numbers could actually be higher. While hospitalizations in our old dashboard and current dashboard hasn't changed dramatically, what we've had done is introduced suspect COVID-19 cases as well that are admitted to our hospitals, both in the inpatient and in our ICU. Because of the influx of cases that we're seeing, the initial admissions were important to understand that if we're seeing a burden of COVID-19. This tab hasn't changed from where we were. It still looks at our overall hospital capacity. Likewise, with our testing as well, we still compare ourselves to how we are with the province. Currently, our numbers have exceeded in terms of where we are in comparison to the province. This is a new slide that focuses on our wastewater surveillance. So what we're trying to identify here is, are the trends in our wastewater data similar to or consistent with what we've currently observing with our Omicron cases? In terms of the entire pandemic overall, from when we started to collect wastewater surveillance data, we have seen a peak in this current wave that we haven't experienced, which in our last peak, which was in this time last year in January 2021. So in terms of our wastewater surveillance data, what it does help us to do is give us a short-term proxy forecast in terms of where our cases could be headed, and how COVID is being managed in our situation locally, and that's usually about a week to about 2 weeks max, ideally in the 1 week time frame in terms of where our cases may be headed. Once again, there are a lot of factors that go into in terms of interpreting this. For example, if we have heavy rainfall, for example, that can really impact the sample and may actually produce lower levels of COVID-19 in our sample. So that's why we wanted to work with our researchers at U Windsor to increase sampling frequency so that we have more data points that we can compare across over time. Lastly, this tab now includes all of our historical outbreaks up to September 1st, 2020. It gives us a good sense of also understanding where and how many outbreaks were there over time, especially throughout the waves that we've experienced and locally in Windsor-Essex. We had, our first and second waves were the driving forces in terms of where responses were in our region. Our third and fourth wave are currently, or especially our fourth wave right now, is where we're experiencing an increase in cases where we've had to manage our resource in terms of our response. But overall, this tab over here gives our residents a sense of where our outbreaks were coming from and what was driving those outbreaks over time. Collectively, though, all of these indicators from wastewater surveillance, understanding our hospitalizations, our testing data, gives us a better sense now with all the changes that have taken place in knowing how COVID is working or taking hold in the community. And we hope to continue to monitor this and to, if possible, identify newer trends or newer data points that we can use to better share information to our residents, such that we can as a community know where we are with COVID and help us to better make decisions moving forward. Thank you.
Thank you for that overview, Ramsey. We will now move to media questions, starting with CTV.
Yes, good morning. I'd just like to follow up on the death of the temporary foreign worker in Essex County. Can you confirm the death yet, or have you an update on the investigation?
Well, the health unit doesn't, we work to protect the privacy of all the people we serve, and I can't really comment further on the facts and circumstances of any death beyond what's already been reported.
Okay. Now, regarding the EPRI summary, what things stood out to you? And as far as the decreasing cases, do you attribute that? I know you did speak about this. Do you attribute that to a less burden of disease, or just the difference in testing?
So I can go first, but I can let others comment too. So right now, because it's segmented to one population, you are also continuously looking to sample that population over and over again. So you will see a decrease. However, at the same time, our wastewater surveillance data has also shown a decrease in the past 7 days, with obviously some peaks there as well. So in terms of where we're heading, it could ebb and flow. We've also seen a reopening of schools as well. So we will continue to monitor to see where we're going. But I would like to say that I remain cautious, but also optimistic in terms of where we are as a region.
Is there any indication that the deaths are from lingering Delta cases, or is there a way to tell what variant or what version of COVID that the deaths could be attributed to?
So currently, right now, Omicron is the dominant variant. Testing for that is also limited too. But in terms of the local data as well from our wastewater partners, Delta decreased dramatically in December. It was between 2 and 10% of where it was identified in our samples as well. So Omicron is currently the dominant variant, and that is what I would say in terms of where our deaths are coming from at the moment.
Okay, thank you. And finally, do you believe that the region is ready for reopening on Monday?
Dr. Nasseri,
Well, it's provincial policy that formulates the reopening framework. I think that as we move towards reopening, we should also monitor what the impact that reopening would be on the metrics of burden of disease. Among them, it would be many of the items that Ramsey had shared today. The current level of disease activity is in part related to the level of public health restrictions that are currently formulated. And as we remove some of those public health measures, it is likely that we'll have a higher burden of disease. Nevertheless, we should monitor if that burden of disease can be managed reasonably in the community, and if so, then I think it's a reasonable approach. If we're not able to manage the burden of disease in the community, then we'll have to reevaluate what the correct approach is. And I'm sure my colleagues in the province are monitoring these data elements.
Okay, thank you.
Any questions from CBC?
Yes, good morning. Ontario's Chief Medical Officer of Health and Multiculturalism Minister has sent letters to WeChew criticizing the now rescinded letter of instruction pausing the arrival of the temporary foreign workers. They also sent these letters after that your letter of instruction was rescinded. Do you think you overstepped your authority and the move to pause the arrival of the workers was discriminatory, as these officials said in their letters to WeChew?
Well, I think that the first thing I would share is that anytime the Public Health Service constructs a letter of instruction, it's formulated by a very experienced legal counsel, and legal counsel always provides us with the best possible opinion on related to effectuating a public health order or direction. The health district works diligently to advance the health of all members of the community. And in part, the reason for the letter of instruction was the fact that we had approximately 2,000 migrant farm worker residents in the community, and more than 10% of that population, that group of our community, were either infected with COVID or were close contacts of someone infected with COVID and required self-isolation. And approximately 40 members of that community were unable to identify self-isolation residences. So I think the health unit works diligently to advance the health of all members of the community, including the 2,000, at that time, approximately 2,000 migrant farm workers. The health unit, on occasion, when there's peak activity, has dedicated up to half of its staff to address the health status of the migrant farm worker community. And I think that the evidence would show that the health unit has tried to make this community a priority in trying to advance their health. The other thing that's now well recognized, but it's worth perhaps sharing, is many of the approaches that we take are in a number of different settings, meaning this. The real issue is the housing situation of members of the migrant farm worker community. And the real public health issue is the fact that in many bunkhouses, 20 people share a bathroom and a kitchen. There could be, on occasion, 6, 8 people sharing a bedroom. And these are conditions that facilitate the transmission of respiratory disease. And anytime people work and live in settings where they're sharing bathrooms and kitchens, there's increased surveillance and action by the Public Health Service. One of the things, and so there are other congregate settings like the group homes for intellectually impaired people, long-term care facilities, retirement homes, and we take many of the same actions. If someone is living in an outbreak situation, meaning that they're in a congregate setting, so if there's an outbreak in a congregate setting, wherever it might be, we do not introduce new people to the congregate setting. The reason for that is we don't want the people who are newly joining that congregate setting getting sick. And so that is just standard routine public health practice. And in formulating this level of public health direction, we were considering many of the same constructs we would in other public health settings as it relates to congregate settings. So at the end of the day, the Public Health Service is concerned about the health status of all people. And that includes the people who currently live in the health district, who work in farms, live in bunkhouses, and are migrant farm workers.
Thank you. Dr. Moore's letter to WeChew does reference a conversation had between, officials at WeChew and officials at the province, and that would have been a few days before you'd issued a letter of instruction with the pause. Did the province not offer enough support at that time? I understand the letter of instruction was based on, doing what was best for the group of people at the time, but, why did it have to go that far? Why wasn't there support offered before that letter was issued?
Well, I can share with you that the Public Health Service in Windsor-Essex and the public health officials have had dozens of communications on this issue that have gone back perhaps 1 year or maybe longer. The lack or the unavailability of self-isolation residences was shared with and was a source of dialogue among federal, provincial, and local officials for some period of time. And we were facing a public health emergency immediately prior to promulgating this letter of instruction. But there had been an extraordinary amount of dialogue to try to secure the necessary resources. I think a couple of things to just add is that when one requires self-isolation resources, it's not only the physical space, meaning a hotel room with a private bathroom, but it's also the psychosocial and medical support so that the people who are in self-isolation can have regular monitoring as well as clinically appropriate medical care. And those were the suite of services that the Public Health Service of Windsor-Essex had requested from provincial and federal counterparts.
But they didn't come in time.
Well, they weren't sufficient at the time. If I could explain it, if I could share it on a more granular level, we can share the exact time dates, but approximately 3 weeks ago, this Monday, we had no one. There was no person in the self-isolation hotel for the migrant farm worker community. By Friday, it had become completely full. By the subsequent Monday, I think there were 270 people waiting in self-isolation, of which 40 still have not found a self-isolation residence. So at the time that we wrote the letter of instruction, there was not sufficient resources to meet the needs of that community.
Thank you. And one last question on this. Why weren't the January 18th and 21st letters that came from provincial officials, why weren't they included in the agenda package for the board meeting that happened?
I'm sorry?
In the last board meeting, yeah.
Go ahead.
In the last board meeting that took place, the letters from the provincial officials were not included, and some board members that we spoke to were not informed of the letters. Was there a reason behind that decision?
So one letter came after our board meeting, and we received lots of communications that are directed to, administration within the health unit. They're not all directed specifically to our board. But we do have a process for making sure that items are reviewed that are necessary to carry forward to the board.
Any questions from Blackburn?
Not at this time.
Any questions from the Windsor Star?
Yes, good morning. Ramsey, I really appreciate your presentation and you breaking down the data as it has changed for us. I'm just wondering if the health unit discussed differentiating its hospitalization data between patients who have tested positive but are not being treated primarily for COVID and patients who are being treated primarily for COVID. That's data that Windsor Regional Hospital and Erie Source Healthcare are both breaking down on their own websites. And the hospitals have indicated there's a significant difference. Basically, there are a lot of patients testing positive for COVID who are asymptomatic, who don't require COVID-19 treatment. Did you have those discussions?
So we've had them internally. Part of that challenge too is that can also go back and forth in terms of the contributing factor of COVID to one's reason for being in the hospital, even though it might not be the primary concern. So just initially for simplicity and in terms of communication, we wanted to include all hospitalizations related to COVID. And also, we also did include suspect individuals who are in the hospital for potential COVID-19 reasons as well. So we wanted to ensure that we were capturing a large scale of the population as well that are currently hospitalized. In the future, if in looking at our numbers over time, if that number does differentiate, we will look to include that. But at the current rationale for not including that, we just wanted to ensure that we were capturing all of our hospitalizations appropriately.
Thank you for that. And separately, I know much earlier in the pandemic, the Health Unit was regularly reporting what symptoms each individual person who tested positive had. I understand that might not be possible at this point, but does the Health Unit still record whether cases asymptomatic or symptomatic?
We do. We do for the cases that are tested and are positive.
I don't know when you last reviewed that data, but can you share with us what you might be seeing there? Are you seeing more asymptomatic people, or is it similar to what we've been seeing throughout?
At the moment, I'd have to go and take a look. I don't have that information readily available.
Okay, thank you.
Yeah, if I could just share as a sort of a general construct, when someone is hospitalized, there are different categories of or different subgroups how COVID might affect their hospitalization. So there are individuals who are hospitalized and their primary presenting complaint is a COVID-related complaint. They have a respiratory distress because they have COVID-related pneumonia. There are some people where the COVID diagnosis may contribute to the reason why they're in the hospital, but there may be another reason that's substantive that's keeping them in the hospital. So if it were not for COVID, their medical problem may have been able to be managed outside the hospital, but now with COVID, it contributes to their admission to the hospital. There are people who present to the hospital who have a disease that's completely unrelated to COVID or are there for an elective surgical procedure or scheduled surgical procedure, and when tested, they have COVID. And sort of, there are people who present with the hospital who have a COVID-related diagnosis and remain in the hospital even after they've stopped becoming infectious with COVID. So depending on what question you ask, might determine what's the best number to try to help you with. I think one measure of burden of disease is, in fact, how many people are currently in the hospital because of COVID. So if the fact that you came to the hospital at a COVID-related diagnosis and you still remain in the hospital even after you become non-infectious, in my mind, the burden of disease is still related to COVID. And that's distinct from someone who might present with an elective surgical procedure who incidentally test positive for COVID. So we're working, and we will continue to work on trying to refine how we communicate this data. But from a public health point of view, the real insight that we want is what is the burden of the amount of occupation or utilization of hospital-related resources due to COVID. There's a hidden part of this which is worth just thinking about. I think at the current time, and Ramsey can correct me, I think it's 130, approximately 130 people are
116,
in 116 are currently in the hospital system because of COVID-19. That's about 1 in every 6 beds, which in another way stating is that those beds would be typically used for other services for patients, and those services can't be provided. So COVID-19 not only affects people's health status with COVID, it also affects the health status of people without COVID because they're not able to access the treatments and services that they should be getting or are scheduled to get because hospital resources are being shifted away to manage COVID-related cases. The other issue is that hospitals typically are running above 90% capacity. Some days are running at 97% capacity. And so it only takes a small amount of additional demand that can cause additional strain on a hospital system that's already tenuous in its resource envelope. Sorry for that long-winded response, but I hope that provides some additional context.
Thank you, Doctor.
Any questions from AM 800?
Sorry, just following up on that question. So of the 116 individuals that are in hospital, are those confirmed cases or is that a mix of suspected and confirmed?
No, those are just confirmed cases.
Those are confirmed cases. Okay, perfect. I think this is more for Nicole. Nicole, looking at the epi summary in regards to the vaccination status, big drop from week 2 to week 3, almost 50%. obviously it's concerning. I know other factors probably played a role with school kids being back in school and whatnot, but just that big drop when you first saw that, just want to get your thoughts.
Yeah, I think we're all concerned, certainly with the drop. We still have quite a number of individuals that have not received still a second dose, but a large proportion of our population still to receive a booster dose. And Ramsey probably has the exact number, but it's close to 200,000, 188, I think, last I looked.
Approximately, yeah. So we have 60% of our children 5 to 11 who haven't received a first dose, and a large population of our individuals between 18 to, I'd say, about 50 who haven't received a booster yet either.
Yeah, so I mean, we are looking at our plans and strategies around our response in our mass vaccination clinics. We have still had very positive responses to our mobile clinics, so that's exciting and maybe provides us with a little bit similar to last year. If you remember, I think we were on sort of a with immunization and vaccinations, climbing, and then we hit a little bit of a wall and had to undertake different strategies and different mechanisms to reach that final number of people. But there still is a lot of availability. All the clinics now have walk-ins for third doses as well. So if anybody was just, it wasn't convenient to make an appointment, now you can walk in as well. We do have, as we identified yesterday in our media release, we do have a more stable supply from the province, and so now of Pfizer. So now have the availability of both Pfizer and Moderna for all ages as appropriate or identified. So yeah, Rob, to answer your question in short, we are concerned about the drop off, but we are regrouping and we'll adjust our plans we'll just continue to provide outreach and opportunities.
I know the province last week, when they announced the lifting of the restrictions, talked about Monday's date and then the February date and then the March date. I know I don't believe anything was said about taking proof of vaccination off the table, but I guess when the public hears March 21st, most capacity limits will be lifted. Excuse me, I might have got the March date wrong there. But do you think that plays a factor if the public hears that and they're saying, why do I need to get vaccinated, for example? Do you think that plays a role?
Yeah, I mean, I'll start, and I'm sure others will add. But yeah, people make decisions around vaccinating for a number of reasons, and certainly we know that the proof of vaccination requirement, is one motivator for some individuals. So changes to that, certainly can I think affect some individuals.
Access to restaurants and other activities for people that are who have received a more up-to-date vaccination schedule is likely an incentive for some people to get vaccinated. The message I would have is the most important thing is to get vaccinated for your health. If you get the booster injection, you're much less likely to get hospitalized or die from COVID. And so that's the real goal, and that's what we'd really encourage people to do. It is likely, however, that there will be some individuals who will perhaps defer getting their vaccination schedule because of the perceived relaxation. But I'm hopeful. I remain hopeful that people get vaccinated, because the most important thing is for your own health, the health of your children and your parents, and the people that you love.
Ramsey, I'm not sure if you have this in front of you, but I know the past few weeks, even prior to that, it was around 50,000 people unvaccinated in Windsor-Essex. Has that number changed at all recently?
I don't know off the top of my head. I have to go take a look.
Okay, thank you.
Ramsey, do you think we could provide an estimate by the end of the day? Yeah, we can provide an estimate of that number, so we can give you a more fulsome number of what the current estimate is.
I think what we can add right now is we do continue to see first doses and second doses. They are very small numbers. So again, it's a really slow crawl against that 50,000. But again, Ramsey can provide you where we're at exactly, but we do still see first doses in our clinics.
Thank you. I just had one quick question. I saw he was on the call. I'm not sure if he's still there. A question for Eric, just in regards to the site, the application. If Eric's on the line, I don't mind if I can ask him a quick question.
Yeah, Rob, I don't have my background prepared, so you'll have to bear with me, but I'm happy to answer a question.
No problem. Thank you. So I know the board discussed this at the last meeting following the council decision, but can you just tell us the next steps now? When do you hope to submit the application?
We hope to submit the application very, very soon. And there's a couple of things that just need to be ironed out now that we have the site confirmed. And once those things are ironed out, then we can move forward with submitting the application. We don't know in terms of how long it will take once the application's out of our hands and it's into the hands of the federal and provincial decision makers and approving the applications. Learning from other communities, that can be about 6 months or so. It could be longer. So we do still, hope to have an operational site by the end of the year. But in terms of our turnaround time for the application, we've been working on the application while we were preparing to go to council. So it's very close to being completed, and there's just a couple things that need to be finalized.
Thank you.
We have time for one follow-up question from our outlets, starting with CTV.
No, thank you.
Follow-up question from CBC.
Yes, please. There's been 44 COVID-related deaths so far this month, the most since last February. What does this tell you about the severity of the Omicron variant and the popular belief that it's milder?
Well, I think from a population health point of view, the number of people who are suffering severe outcomes is a function of the disease itself, but also the number of people affected by the disease. And since Omicron is more infectious and there are more people infected, then it only follows that there'll be more people are hospitalized and a greater proportion of people who die. And so I think that's the population health challenge that we're faced with. Perhaps Ramsey can supplement that or correct my assessment. But
no, that's correct. It is more transmissible, so you're seeing a lot widespread acquisition in our community. As a result, you will see a subset of those individuals be hospitalized and then potentially die due to COVID. So that's you are correct.
If I can just add, we also do know that it is still a great risk for individuals, certainly who are unvaccinated, but also individuals who are older in age, as well as individuals who have other, chronic health conditions. And, we have done a lot of work over the course of the pandemic to ensure that we do prioritize and focus on protecting those individuals because the severe outcomes for them are likely the greatest.
Thank you. And I'm so sorry, can I ask one more quick question about the changes to metrics this week?
Yes, go ahead.
We did make changes to the case counts. We're classifying them now as high risk due to the changes in testing availability. But is this still, a helpful metric to track the burden? When the high risk cases have dropped significantly from where it was previously?
If you reference back into my slide deck, I'd actually canceled out case counts and weekly incidents because of the lack of comparability to previous metrics of the past. We do present it just because we want to keep some sort of continuity, but in terms of our decision making and what we look towards, we actually look at other aspects of our data, including hospitalizations, wastewater surveillance, our outbreaks. Even on our figures presented, we also differentiate between all of our previous cases and then our current high risk cases, with the focus being now on our high risk cases specifically.
Thank you so much.
Any follow-up questions from Blackburn?
Yes, I wanted to ask you, with the number of people going out and getting their vaccinations now, first, second, you said those numbers have been smaller. Are you still confident that we can hit above 90% vaccinated in this community?
As doctors, we're confident of something we typically don't use. We'll do our very best to encourage people to get vaccinated, and I remain hopeful and optimistic that more and more people will get vaccinated. I think we'll have to, obviously we're concerned about vaccine uptake rates, but I hope, and we're doing everything we can at the local health district level to provide access to the vaccine. I think the real challenge now is for individuals to make that affirmative decision to get vaccinated. And I know we shared this message before, but it really is up to the individual served to get this beneficial medical approach. And so I remain optimistic that we'll hit that 90% target. But I do think it's up to community members to really make that effort to get vaccinated.
Just to also add,
Sure.
we did hit a milestone too in terms of where we were towards the end of last week, where we had over 80% of our residents 5+ who are fully vaccinated. So we are optimistic, and it might be slower than we have anticipated, but we're hopeful that we will get there with time.
Yeah, and just to add, I think, optimistic, and we do, at least right now, have the capacity and the vaccine to achieve that goal. At Dr. Nessathuri's point, it's just a matter of getting that cooperation from our community.
So how do you, I guess you mentioned possibly changing your strategy. Have you thought a lot about how you can change it in the future to convince these people after 2 years that they need to get this done?
Public health, I think, and certainly Ramsey or Dr. Nessathuri can add, but public health strategies are always refined. We're always looking at our approaches and ways that we can improve them, and especially when it comes to outreach, education, awareness, promotion. When I said changing our strategies, I mean, for the past month or so, we've really focused on some of those mass vaccination sites. And as we did before, we shifted away from the large centers where, we're no longer getting the floods of individuals, and focused more on, a mobile strategy or in expanding that effort to try to get folks that, for whatever reason, aren't coming to sort of the mass site, and that maybe need different points of access, different education, and different outreach. So, that'll be one of the shifts. But as well, we are working with a number of partners across the community, to focus on some of those areas and neighborhoods that we know uptake is a little, is lower.
Thank you.
So if I could share, it's a very fair question that you ask. What can we do to improve the vaccination rates? So if I could share this, I think that if we are going to move towards a more normal, COVID is not going away. It's likely that we're going to have COVID in our community in some form, in some variant, with some burden of disease moving forward. That's true for COVID, and that's true for influenza. So it's true for many respiratory diseases. It remains within our community. Like influenza, the way that we manage influenza in part is have an annual influenza vaccine. and it's likely that moving forward that we're going to have some regular vaccination for COVID in whatever its variants or variations might be. The way to effectuate that is in part education, in part it's improving availability, which is what we do for the flu. But for some vaccines, it's also requires a level of affordance or a level of reporting or direction. So in Ontario, we have the Immunization for School Pupils Act, which was a very progressive piece of legislation, and it provided a framework for young people to get vaccinated and allow the Public Health Service to monitor and support the vaccination of young people. That has benefits for young people not only while they're in school, but while they enter into adulthood. The Board of Health in Windsor-Essex has passed a resolution asking the provincial authorities to add the COVID vaccine to the list of vaccines covered by the Immunization for School Pupils Act. And I think that is one policy lever that we as a community can exercise to try to improve vaccination rates. And I'm hopeful that that does come to fruition, and that COVID vaccination is included as the suite of vaccines in that statute, just like the polio vaccine is.
A follow-up question from Windsor Star.
No, thank you.
A follow-up question from AM 800.
Just one quick one, Doctor. With the some restrictions being lifted this Monday, does that mean the letter of instruction? I know I asked this last week, and you said you're going to look at what the province was going to announce. Does that mean the letter of instruction that you issued back December 5th, I believe it was, has been lifted now?
Well, we'll review the letter of instruction and as we always do, and then make a decision based on that. So we will review the letter of instruction and see if it's appropriate at the current time.
Thank you.
Thank you, everybody. Have a great day. We will meet again. Our next scheduled session is Thursday, February the 3rd. Thank you.
Thank you. All the best. All the best.